um, by Ministry of Health and CEPHEID. And today we're going to discuss the effect of funding freeze on viral load testing services and the recovery measures. We're delighted to be joined by a man who doesn't need any introduction, Dr. Sivile Suilanji, who's our HIV specialist and HIV lead for the program, and also one of our top infectious disease physicians. Dr. Sivile, we're so grateful to have you today. Thank you for joining. And network, just a few house rules before we get started. Kindly ensure you mute your microphones during the session. And if you've got any questions, kindly post them in the chat box and we shall be able to attend to them. Same thing goes with comments. At this point of time, I'd like to welcome Dr. Sivile once again. Thank you, Dr. Sivile, and over to you.
Hi, Dr. Nick, and thank you, Network, for coming and finding time to join us as a program. So, as you know, the program we work with different partners, and we've done some work with CEPHEID. CEPHEID, they are the ones. I don't know. Can you see my slides?
You can. It's just not in slide again.
Okay. Okay. You can see my slides?
Yes, your slides can be seen, but it's just not in the slide presentation. Yep, perfect.
Are they in the slides presentation now?
Yes, they are. Perfect. Thank you.
Okay, yeah. So, yes, so apologies for that. So I think for those of you who don't know me, I'm Sivile. I'm with the HIV program at Ministry of Health. I'm a technical advisor there, really just coordinating what goes on with our HIV programming. Yeah, so as a program, we've been working with CEPHEID. CEPHEID are the ones that support our gene experts, both for TB and services, HIV services, and also cervical cancer testing. We all know what has gone on. So we had these effects from funding freeze. We had PEPFAR Global Fund, and there's this just general reduction of HIV funding that we had gone through, and it has impacted us a lot. So we are trying to ensure that there's some continuity of services. I'm sure some of your provinces, you did receive staff from HQ coming to assess what is going on with HIV services. So we've incorporated with CEPHEID to see if we can use the ECHO platform, and partially they'll support some physical training for laboratory personnel in viral load and TB testing to just ensure that we come back to where we recover our services following the effect of the funding freeze or the stop work order. Yeah, so this afternoon we are just going to look at how this funding changes environment did affect our viral load services in particular, and what we can do to recover. We still have some of the challenges. We have some colleagues on the panel. That's Dr. Ziambo and also Judith, who manages the lab services at HQ. And together we'll look at what we can do. We do accept that there's some gaps, but it's us to meet and see what we can do. And we'll have some normative instructions as well on how we can proceed. So we are really grateful to CEPHEID for their sponsorship, their support to the HIV program to make sure that viral load testing does continue. So you can scan this QR code it will help you get some more materials from CEPHEID, viral load use. There's quite a lot of um, changes, but also questions that we do get over viral load testing, especially when you have to use the point of care tests. For your own information, this is the path that we want to go because the point of care tests are cheaper. They don't require, courier and so on and so forth. So you see us engaging with CEPHEID a little bit more in the future, but it will give us it will give you some knowledge. When you need it, you have to use the card, the plasma, when do you store the sample, and so on. So want to still go ahead and deal with those issues. Yeah. Yeah. Otherwise, this is the layout of my introduction. I'll try and make it short. I know it's your lunch time. And after that, we'll have some support, some feedback presentation or some feel from Muchinga province, what's really going on, and that will launch us into the discussion. Yeah. So otherwise, we all know from as of September, this was our performance as a program in terms of the 95-95. And equally, we are doing a little bit better among children as well than we used to do in the past. Viral suppression has gone all the way up to 95 among children. With regards to adolescents, we are almost reaching 95 for AYP as well, adolescents and young people. But we do have gaps in our response, and mainly among children. And also we are seeing that signal among the elderly. You can see those areas that are in red. Now, our recommendation for viral load testing still stands. And even as we are going to change, we are going to present on the minimum package and other things that we want to change with regards to our HIV services. But this will remain. So,
recording in progress.
yeah. So, apologies for that. Yeah. So our recommendations still remains, and viral load testing is the gold standard of monitoring individuals that are receiving ART. We are reserving CD4 testing for only advanced HIV disease recommendations. There will be some changes that you hear that will present over 3-monthly testing for pregnant and breastfeeding women. This has changed, and also baseline viral load has been discontinued. We've discontinued, you can see there, the genotype after first line treatment. So just to help you see what changes we've made, and this is aimed at streamlining our services so that they're slightly cheaper. We all know what the viral load is, and that is one of the goals for indeed HIV ART treatment, and that is to have individuals suppressed. And suppression is the biggest predictor of outcomes. We know better than a CD4 count in these individuals who's on ART. Our recommendations remains that individuals who should have a viral load test at 6 months, then at 12 months, if they are suppressed, thereafter, it's annually. And those indeed that are a bit low level viremic, immediately we should start some enhanced adherence services, but you should maintain the ARVs, and if they are on multi-month prescription, they should continue. Those that are undetectable, it means the ART is doing fine. Those that are above 1,000, they are unsuppressed, and these need ESC, and you still have to repeat the viral load at 3 months. Once they are still unsuppressed, you switch them to second line, and we do not recommend genotype at this point. So that has changed. For pregnant and breastfeeding women, you hear a new guidance, but otherwise would like a viral load at booking, another viral load between labor and delivery, and booking. If there's a 3 months window there, we'll have a viral load at peri-conception, peri-delivery period, that's 4 weeks within EDD, and thereafter, only one viral load at 6 weeks. Yeah, so that has changed, but we'll have another presentation in this series to go in depth to look at the minimum package changes which affect viral load. But I thought I should say that. CD4 testing is only indicated for those individuals that are either initiating ART, re-engaging into care, or they are viremic, or indeed they are severely ill and hospitalized. Yeah. Otherwise, the recommendations have remained almost the same, and this chart shows a pictorial figure for the recommendations. The message is the same. Similarly, for pregnant and breastfeeding women, but this has changed as I'm going to explain. So pregnant and breastfeeding can be considered for 3 monthly MMS, but they should still have their antenatal services done. Children, the follow-up is similar to that of adults. I wanted to mention a little bit on those who are reinitiating into care. We don't recommend a viral load there and then, but you have to do a viral load to have a results at 6 months. So actually the recommendation is a viral load should be done so that you have a result at 6 months. And just a recap on enhanced adherence counseling. We always think that adherence counseling and viral load suppression go hand in hand. And we always encourage our trained healthcare providers to be the ones who should be providing that enhanced adherence service. Yeah. Yeah. Now, also critical to note that we know that individuals that are undetectable cannot transmit. And this is the U equals to U, or U equals to 0. Yeah. So very important. Yeah. That being undetectable, there's a 0 risk of transmission to sexual partners and minimal risk for PMTCT or vertical transmission. And we know that this is the pathway to eliminate or to control HIV, the so-called treatment as prevention. I'm going to just go through some performance or viral load that we've had during this period. So basically, we've been doing very well. You can see our elevation on viral load testing over the years. Believe it or not, in 2018, our viral load coverage was like 30%. You can see that 400 tests, 1,000 tests, which over the last 5 years or so, we've almost increased them by 4 times. Yeah, so, and the suppression rate was at 61%. Now we are in the 90s. So there's been a lot of work And this is the work that we don't want to lose in this period and going in the future. We still want to maintain this much work over close to, 1,700 to 2,000 tests every year. That's our 2 million tests every year. That's our target as a program. Yeah, and this just shows how our suppression rates have been over the years. If you look at last year's data, and this is by age. So fantastic performance that we've had over the years. You can see this is also even in the pediatrics. Now I did show you that suppression rates are now approaching towards 95%. If you look at by patient, if you look at just all the data, this is from the DISA, from the lab base, because some of these are repeat tests, still are around close to the 90s. Yeah. For those above 15, they are fantastic, all the way to 96%. So we've been doing very well. And this is pretty much across the whole province. All the provinces, their performance has been super. In terms of violence suppression. So has it been for the children as well, and testing. Yeah. So our performance really has been a marvel, quarter by quarter, for all populations by and large. And here you can see even the viral load coverage trends. You can see that last year, Q4, September, were at 87%. Now, this is very, very high. Our target has been 95, but we are very, very happy with this. Our performance is commendable. Despite this performance, when the stop work order came in, we've been affected. And this is what we are going to discuss this afternoon. The performance, the effect that the work stop order did have on our viral load services. So we have close to 2,800 facilities in the country. And I can tell you all these facilities, they were impacted by the work stop order, but we tried to ensure that services did continue, and they were providing some services in one way or another. And again, we thank all of you on the platform today that it's your work that made sure that services did continue. Despite that, we know that there were variations, and there are variations that have continued after that. Now, we do follow close to 22 indicators, including the viral load suppression, which is not being shown here, but because it's coming from the DISA link. Yeah, but this is for the HMIS. You can see that on top, the HMIS report did not fall that much between December and February, but you can see that all the indicators were affected. Yeah, due to the stop work order. This is when the President Trump announced that we stop, there's a funding freeze for PEPFAR support. You can see that you have things like VMMC, new circumcised, fell by 70%. And you can see that PrEP initiation fell by 60%. So we were really affected as a program, yeah. And this is just to show other areas like testing. We were affected in all the areas. You can see the testing. I'll not go deep into this for the sake of time. Yeah, but there were some. We saw reduction. Yes.
I couldn't find reduction in testing in your Apple Music library. You can ask me to.
Yeah. Similarly, on starting individuals on treatment, There were some reductions as well. You can see that this was even worse for the children. Yeah. Now, I would like to also just give a word on current on treatment. We did lose close to 53,000 individuals because of the stop work order. And that's a lot if you think about it. 53,000 and 2,000 of those were actually children. Yeah. So this is how much we were affected. And this is just a graph. For viral load suppression or and testing, you can see that the tests, viral load tests fell by 28%. So we had over 35,000 individuals who needed to have a viral load test that particular month and never got that test done. Yeah, suppression rates were almost the same, but you can see that absolute number of those who had a suppression, a viral load suppression result fell by 27%. And you can see that the results nationally were even more grave in terms of percentage for the children. Yeah, 34% reduction in viral load suppression. And this is just a picture showing the same. You can see the absolute change there for viral load test and reduction. You can see it's close to over 30,000 individuals didn't have the tests that they deserve done. And we try to zero in province by province. You can see that for viral load testing, which is the denominator there, for Eastern Province, there was a fall between December and February. You can see a fall, but there was a recovery around March. This is that denominator where how many people did we actually test for viral load. Yeah, so Eastern Province was less impacted. It looks marginal, partially. It's, as you know, it's one of those provinces that even now the package, they're still providing all the services. The impact was minor, yeah, but we can see that in other provinces, for instance, Northern Province here, the figure was far much bigger. Over 1,000 individuals didn't have that test done for that province. Copper belts, similarly, those who are eligible and those who had the coverage, we see it falling from 85% to about 76%, almost a 10 percentage point in the coverage of viral load suppression. Southern Province, obviously, this just like Eastern Province, the service were a bit maintained here. We do not see a lot of viral load coverage changes. You can see that overall, there was between December and February, there was a fall of about 14%, 4 percentage points. Yeah, from 88% to 84%. Yeah, but even our high performing provinces, they were affected. Luapula had similar challenges. You can see it was drop in all the indicators. The viral load denominator here, which is how many tests were done, fell by 9%. And you can see the number of individuals who missed out on a test. So you see these changes, and this is I know 9% seems small, but if you think of 4,000 individuals, these are a lot that could have a test, but never had a test, and we need to find ways of are improving. Central Province, their data shows a big reduction between January and February, from 78 to 66, slight recovery. But again, those people who did have the viral load, didn't have the viral load test needed to, needs to be found, need to be followed. And the reasons are many. We had disturbance in the courier system during the stop work order, reduced number of laboratory personnel. We know a lot of the personnel are supported by partners, and so they couldn't run the samples. Yeah, and also just sample collection itself, the phlebotomies and so on, the DBS collections for those who use those, yeah, because healthcare workers and community healthcare workers who are supported by partners, we are not coming. We know there's quite a bit of recovery where these people are back, the courier system is back, but we still have challenges, as you can see. So, and the challenges mostly are with the stock status. While we are more or less adequately stocked on the point of care tests, about 7.7 months, we know that conventional tests, we are stocked out centrally, and we are depending on the reagents that are available in sub-national level. So here we have a challenge, and we need to discuss. I'd like to hear what's happening in the provinces and how we can move in. And we expect that by now, mid-June or so, this should be starting to come, and then there'll be a backlog to distribute. Yeah, but the reagents haven't come. And this is what we suggest. In the meantime, let's ensure that we use as much POCs as possible, especially those sites which are designated as POC sites for viral load. We recommend intra-dist courier to POC sites, that's point of care sites for those, especially for priority samples like for pregnant and breastfeeding women, those on ESC children and so on, those with suspected treatment failure. In other words, what we recommend is, we know that some conventional sites might not have the reagents, but we ask you, that can some of those samples, especially for priority populations or samples, can you send them to some POC facilities within your districts? I think that will help. That's intra-district, and also inter-district provincial courier. Yeah, I think this has been happening, say, I know very well, between Wapula and the northern province, where the Kasama machine, conventional machine hasn't been working for some time, and they are moving inter-provincially to Wapula. So we encourage that. Can we start seeing that as we are waiting, so that these services do not collapse? We don't really want to collapse our services during this period. Yeah. But by and large, collections of viral load samples for all eligible recipients of care should continue, even sites without stocks at the moment. You can store them and run them later. Very important that we start still monitoring our suppression rates. Yeah, there are some of the things that you should watch out for. Like I've said, we are going to present the minimum package later, but right now we can go ahead and stop doing the baseline viral load testing. This has been discontinued. There is some adjustments we can do, like I've mentioned, for testing, viral load testing, pregnant and breastfeeding women. And those who have reagents, we need to continue tracing the backlog. Our CQA system, we make the list of those due, let's trace them. The community health workers are back, so that we can deal with the backlog as well. So this is I've hurried through the presentation. That's because I wanted to have some discussions over our experiences in just the viral load testing, what's happening. And at this point, I'm going to ask our colleagues from Muchinga to just run us through in their experiences, and we'll open it up for the discussions before we all break off for lunch. Mr. Matafwali, are you there? And the colleagues from Muchinga?
Thanks, Dr. Sivile. So any colleagues from Muchinga? Mr. Matafwali?
Provincial biomedical scientists? The Muchinga team, I think they've sent the presentation to me. You can pick it up and we just hear how your experiences have been in Muchinga.
Hello, good afternoon, Dr. Sivile.
Afternoon.
Thank you so much. I don't know if I can share my slides.
Please go ahead. I think you are allowed to do so.
All right, thank you so much. I'm Andrew Matafwali, coordinating the HIV from Chinga. We just want to share the progress so far concerning the viral load. So I'll start with the laboratory stock status that we have as a province. So those are the facilities where we have the EID, the VL, especially from the point of care, and also from the central lab, that is the PCR lab. So as you can see, that is our stock status from Chinsali District Hospital. I think we still have the commodities, but we have POC facilities or sites that have a little bit of a challenge. That is Mlilo Solo for the EIT. We do not have currently for Pumba, as well as Ilondola, where we have the challenge. So as PHO, for the point of care, we have at least enough cartridges that can last us through maybe for 2 to 3 months. Then we also received some reagents, that is at the PCR lab for the Panther, that we can do the VL and also EIT. So in stock currently we have around 135 kits.
Hi, Mr. Matafwali. I think you've dropped. Your connection has dropped. If you could just repeat what you said in the last minute.
All right, thank you. I'm just trying to reconnect. Hello, are you able to get me?
Yes, we are. Please go ahead.
All right, thank you so much. So I was just showing the stock status for our POC and also the PCR. So we received some reagents, especially for the Panther, for the Chisari General Hospital. And that slide just shows the POC that we have as a province. Then just on the progress VL, I think we have moved basically from the stop work all that time. I think we dropped up to 85%. That is the viral load coverage. For viral load suppression, I think we maintained at 98%. So looking at the accretion and also attrition as of 5th June, this is what we have managed. Remember that Mchinga, we dropped from 36,000 to around 30,000 of our TX car. So currently, we are around 35,421. And for VL, we have improved from 85 to around 89%. So that is the picture from Chinga. Thank you so much, Dr. Sibili.
Thank you, Muchinga. At least we do have a feel of what is going on. Do we have anyone from Judge? I can see there are some questions. I don't know. For the sake of time, do you want us to go through the questions right now, Dr. Naik?
Yes, sir. I think we can start going through some of the questions.
Yes.
This time, I'd also like to invite our panel of experts. We have Ms. Nziache, Judith, thank you for joining us, and Dr. Kozia Ziambo. So I'm just going to start with a few questions. And also, if you have any questions, kindly raise your hand, and then we'll be able to ask you to unmute. So we've got a few questions. We've got one from Dr. Mushisha. So looking at the minimal package, no genotype for first line, what impact do we project in the environment of Cable and other selected sites which have shown an increase in patterns of resistance? For the viral load testing of 35,689, which were not done, is it possible to highlight which provinces were mostly impacted? And was this as a result of courier systems or main lab functionality? Maybe we can take that. It's quite a handful.
You want me to take that one? Okay. I can't see it. Okay, okay. Looking at the minimum package, okay. What impact do we project in the environment of Cable and other selected sites which have shown an increase in pattern of resistance? Yeah. Yeah, so just from another meeting where I was presenting the minimum package and I was being asked the same question. Yeah, so as you know, would have loved to continue the genotype after first line, but you have to look at the cost. Yeah, so there are some things that you have to let go. Yeah, it's not recommended by the WHO. The rest of we are probably one of the few countries, if not the only country, that has got this recommendation. So in the environment where the desire is to have a package that is cost effective, unfortunately, these are some of the things that should go. So HIV drug resistance, probably we would have to go on using some surveillance data and so on, and some research work here and there, but not routine, yeah, to have that information. And where the Cable comes in, we hope that in the near future, I'm being forced to preempt certain things, but those who were on the echo yesterday, you did hear that we'll be getting lenacapavir, I think by early next year. So Len doesn't have that transmitted resistance with the instis, so probably that would help as well. And that's one of the advantages that we are looking forward to having lenacapavir. Yeah, but it's something that would have loved to continue. We just don't have the money. I did try and present as many provinces as possible to see how provinces were affected, and I'm sure I think you are able to see different changes, and we had a sample. And I think individuals from the provinces are here to explain what really happened because of those drops, especially that this data is from them and not ourselves. I can see other hands.
Thank you. Yeah, we've got two hands, but we just got two more comments which you can take from the chat box, and then we can ask Dr. Jackson and Dr. Chimwemwe to go ahead. So Henry and Cynthia, thank you for your questions. They're asking the same thing. Discontinuing of the baseline viral load, will it imply recency testing as well? And I think that was also Mr. Munkombwe's question. And then Mr. Emmanuel Mungomba has asked, after how many months of being IIT can the re-engage be subjected to CD4 testing? And then we can go to the RINs. Did you get that?
Okay.
Yeah.
Yes, I did. Yeah. So re-engagement after IIT, that's 6 months. Initially, PEPFAR used to put it at 12 months. We've reduced it to 6 months. Someone should have a CD4 count, especially if they are not in care, so that they can be beneficiaries of the HD package. The other question I've forgotten. I think I'm losing my immediate memory. Yeah.
Was the discontinuing of the baseline viral load, does it imply?
Oh, thank you. Thank you. It must be early Alzheimer's disease. Yeah. I'm sure all of you have seen that there's now an effective therapy for Alzheimer's disease. Yeah. So those of us who are aging have hope. Yeah. So for baseline viral load, yes, we are doing away with recent testing as well. And I did see a question that whether this is permanent. Yes, it is permanent. But I've seen comments like I've been running too fast over these recommendations. We will have a proper presentation. I think we can share the schedule for this presentation. Should be either the next installment or the other one that the topic is on the minimum package. And we will give a talk on the minimum package on the main echo, where we will not look at laboratory that's testing, but all the other things now, HIV testing, because there are changes there as well. Yeah. So if the echo team would like, we can even have that next Monday or the other Monday. Yeah, but we are now ready to have that presentation. I've seen a comment from Judith. Probably she can say something as an expert. I think she runs the program for viral load and she knows why we dipped. Judith?
Good afternoon, and thank you so much, Dr. CEPHEID. So I was just responding to the question on the 35,000 that viral load tests that were not done, that the contributing factors were, it shows that our sample referral system as well as the stockouts. So as you are aware that our sample referral system is actually 80% supported by the USG funds partners. So when that happened, we now had to start relying on other modes of transport like the ambulances and even people who are moving around. So that contributed, as well as the stockouts. The commodities which were supposed to come in, the testing commodity, the reagents, where the orders were cut off. So that is what led to the stockouts. So that explains why there was a dip. So we had the samples, but there was no means to move them to the lab. And those that got to the lab, there were no means of testing them. This includes even our POC cartridges. They only came in recently, but at that time, we were stocked out. So we were really in a bad place. Thank you so much.
Great, thank you. Thank you for that contribution, Judith. So we have two hands raised. We've got one from Dr. Chimwemwe Zulu and Dr. Jackson Mwewa. I think we go for ladies first. Dr. Zulu, you may go ahead, and then we'll get Dr. Mwewa on. Can you unmute yourselves and go ahead? Dr. Zulu Chimwemwe. Okay.
Hello. I was failing to unmute. I needed permission. Can you hear me?
Great. Yes, we
We
can.
can hear you, Dr. Chimwemwe.
Okay. Thank you very much. Thank you, Dr. CEPHEID, for the presentation. I had two questions. My first one was on the viral load. You mentioned the the new adjustments to the pregnant and breastfeeding women. So just maybe clarity, is this something which will be finalized when we have the series on that? Or what is the guidance going forward as at now with the about 4, I think, which you mentioned going for viral load? Then my other question, though away from viral load on CD4 count, you mentioned it will only be done in particular populations, but then I was wondering about the CD4 count for the stoppage of septrin in the parent breastfeeding women as well as the children. How are we going to go around that? Will we still have that aspect for those two populations for us to know when to stop? Or what is your comment on that? Thank you very much.
Dr. Nike, can I answer?
Yeah, please do go ahead, sir.
Thank you. Thank you, Dr. Chimwemwe. Yeah, so the CD4 testing, I'll start with that. We've done away with the septrin prophylaxis. Yeah. So apart from children, and you use age, and also pregnant and breastfeeding, so you know when somebody's pregnant. So otherwise, you only need those who have HD to diagnose, and maybe even once someone has HD, you screen and so on. The septrin prophylaxis is not recommended. It's not something that we will carry on. Yeah. I do get a question why. The reason is the evidence for people who are suppressed, probably. The trials for septrin was done in the pre-ART era. So the question of what's its role when we can give ARVs and suppress individuals to prevent things like, PCP and so on a population level. Maybe you can target individuals who you see, check, and things like that. Yeah. So unfortunately, we are doing away with septrin prophylaxis. Yeah, but we'll discuss those things when we look at the whole package. Yeah, that's why I was trying to gloss over those issues. I think the intention for today's presentation was just to discuss the importance of us continuing to test people with a viral load and to differentiate the CD4 count. The other question was on, what was the question again? Pregnant and breastfeeding women. Similarly, we need to start now once you get the message, because this is official communication. Yeah, so viral loads, you only do it if there's no viral load that is within 3 months at booking, you can do it. Do another one in the meantime, then one at delivery. 4 months before delivery, then one at 6 weeks. That's all. Then after that, they go into normal. So we have to remove a little bit some time points for viral load. You would save something like 10% of tests. That we do. So that's a bit of money. So we should start doing those things now.
Awesome. Thank you. Thank you, Dr. Sibile. And I hope that answers your question, Dr. Chimwemwe. We've got 4 more minutes. I think we'll start wrapping up soon. Dr. Jackson Wewa from USAID, please go ahead and unmute your microphone, and you may ask your question or contribute. Thanks.
Thank you very much, Dr. Sibile. That was a very informative and exciting presentation. As you can see, most of the question actually is based on viral load disease, show how important viral load monitoring in HIV programming. I just wanted to find out, I think another thing for viral baseline, that it came as a game changer in identifying KPs. What had been put in place to ensure that as it's been scrapped off, the KPs will be identified, because this actually game was a game changer where we used to do reclassification to ensure that we only pick those real TX news as the TX in HIV programming. Then that's the first question. Another question I wanted to find out, when is the minimum package going to be effective? And are we going to have an addendum on when it's going to be effective? I submit share, I think.
Yeah, so the last question, it's effective now. So we can start implementing those things that we can. Obviously, we are kind of in the transition period. There are things which we've stopped, but we said they're not recommended, but projects still have funding. And we expect that this transition period should go on till maybe September. Once the copious ends, once things change, we might have to go full throttle in what that basic package. Yeah, but we encourage that certain things should start happening now. So we are already in that transition period. The baseline viral load, yeah, you agree with me that that's the reason, and it was so helpful. What we should do better to deal with the recycling, the silent transfers, is maybe strengthen our counseling, talking to individuals better, the referral writing, documentation better. We hope that in future we'll have a better EHR system that can identify somebody who's already been in treatment, but probably that's not in the immediate. It's like, midterm. I don't see it happening this year or the other year. Yeah, especially that we've been disrupted. Yeah. Yeah, so it had its use, but as you would know, we had to find areas to save, and it was one of those areas that we had to save some costs, yeah, efficiencies, yeah. But I agree the use, yeah. Thanks.
Thanks.
And it's good feedback that you guys appreciate what it was doing, yeah.
Thanks, Dr. Seville, for that. Just a few comments. So I think this is a bunch of similar contributions. So is there any memos or protocols, or could you share the minimum package so that we can start implementing it? And I think, yeah, I may take note of that. And then we've got one question regarding, away from the topic, wanted to find out on PrEP. During screening, and are clinicians supposed to test the STIs and HPV before initiation? Has it been affected as well? And then, yeah, maybe we can, and then please share the minimal package again. So this is regarding PrEP.
PrEP. Oh, yes. Yes. So, yes, we encourage that STIs are tested in people who have PrEP, including things like hepatitis B, but they are not a contraindication that if someone has an STI, they shouldn't get PrEP services. Yeah. So that should be done. Concerning the minimum package, we will circulate. You definitely get hold of it and watch out for the main session that probably myself and Professor Mlenga will give. We're trying to find when both of us are available and the ECHO team can give us that. So then we'll be able to give the whole package and answer a number of your questions that you've given. Yeah. But it's always nice to hear the feedback that people did appreciate some of the things that we had started doing. But unfortunately, times have changed. Yeah.
Great. Thank you so much, Dr. Seville. I know we're getting slightly over time now, and it is lunch hour, so we won't take much of people's time. Very grateful for the network, very interactive session we've had today. And definitely in the coming weeks, we're going to have more and more deeper discussions regarding this, which you will be sharing the links, and please stay tuned for that. Like Dr. Seville has put it, I know there's some certain comments we may have not attended to, but if you could kindly send them to emails, then we should be able to attend to those. At this point of time, I think I'd like to thank the network, thank the panel, Ms. Misiacha Judith, and our Dr. Civile for this lovely presentation. I know it might have been too quick, but we will go through it in detail once again in the upcoming sessions, and we are excited for that. So once again, thank you, Network. Thank you, Dr. Civile. Thank you, our panel, for joining in. And we shall see you next week, Tuesday, for the next session. We'll probably send out the email, the invites soon. Thanks once again.
Thank you. It was my pleasure to discuss viral load testing with all of you. Thank you.
Great. Thanks. Thanks. Bye-bye.
Bye.
Bye. And those asking for this presentation, it will be uploaded to the iEcho platform, and you shall be able to access this entire presentation from there. So just ensure that you also subscribe to the iEcho platform, and whichever echo you actually attend, you're able to access all these presentations from there. Thanks. All right, you enjoy the rest of your day, and goodbye for now.